So I'd really like to welcome everyone here today. I'm Ali Ferguson. I am the chair of the WIFPIC's Allied Health Committee, and it's wonderful to see you all join the call for this really great topic webinar presented by Georgie Pazimilis and Cameron Greenland. They're going to be talking on the clinical use and implementation of lung ultrasound for physiotherapy. Now, I'm just going to give a little short intro for both Georgie and Cam. I'm lucky enough to work with both these wonderful people. So Georgie is a senior physiotherapist in the critical care team at the Queensland Children's Hospital with over 18 years experience working in both adult and paediatric intensive care. Georgie represents physiotherapy on the PICU Allied Health Leadership Team and chairs the Australian Physiotherapy PICU Network. She delivers simulated learning to Australian universities as well as workforce training around the state of Queensland. Georgie developed the protocol for the use of ventilator hyperinflation in paediatrics at QCH and is leading the clinical use of lung ultrasound for physiotherapy in PICU in Australia, including a research project investigating the use of ultrasound of the diaphragm in children. She is one of 7 physiotherapists in Australia and the first in paediatrics to have completed her certificate for allied health performed ultrasound accredited by the Australian Society for Ultrasound in Medicine. So welcome, Georgie, and thank you so much for presenting to us today. Cam Greenland is a senior physiotherapist at the Queensland Children's Hospital with over 10 years experience working across the respiratory and critical care caseloads. Cameron completed lung ultrasound training in 2019 and has since used it in clinical and research applications across these cohorts. So a big welcome to you both. Really looking forward to the presentation, and over to you.
Thanks, Ali. Good morning, good afternoon, and good evening, everyone. So before we begin discussing lung ultrasound and its clinical use for physiotherapy, could we please ask you guys to turn your videos on? So this is hopefully an interactive session for everyone, and so we'd love to see your faces, please. We will pause for questions at various points throughout the presentation, so of course feel free to ask questions at this time, or of course you can pop your questions in the chat box as well, and we can look at those points as well. You can also contact us by email at a later point if you have any questions that you weren't able to ask today. So recently I was showing my 7-year-old some of my favourite travel photos, and in particular some safari shots from a trip to Africa. So my favourite animals to observe when I was in Africa were the elephants, and it turned out that so were his, but for a couple of different reasons. He was particularly interested in a video that I'd been taking while an elephant decided to do a wee. What is it with boys and toilet humour? So he says to me, "Mama, that's enough wee to fill our whole house." And he says, "Mama, aren't we great? Isn't it great that the elephant was in Africa and doing a wee and not in our house?" I was like, "Yeah, buddy, I'd say we're pretty lucky not to have an elephant in our house for a couple of reasons, I think." But I think in his mind, this epic wee looked something like this. But back to the elephants. So despite mostly being associated with loud trumpeting noises, these huge animals actually communicate through infrasound, and that's the term used to describe sound which is below the range of human hearing. These low-frequency noises at 1 to 20 hertz can keep them in touch over distances of up to 10 kilometres. So I can imagine some pretty impressive games of elephant Marco Polo between the little elephants. But today our focus will be ultrasound, and these are the sound waves that are above the range of human hearing at frequencies of greater than 20 million hertz, and more specifically lung ultrasound and its use by physiotherapists in the PICU. Now, although lung ultrasound by physiotherapists has been around for the last decade or so, it's not had the same speed of uptake in the paediatric space, and even in adults hasn't always had the same clinical uses as we have found at the Queensland Children's Hospital in Brisbane, Australia. We're the first paediatric centre in Australia to use lung ultrasound within physiotherapy, and it has enabled us to provide better care to our patients through numerous avenues, including more targeted treatments, measuring effectiveness of physiotherapy techniques, and further informing clinical decision-making. So please have your devices ready and go ahead to submit your answers to the following 4 questions. Please use the emoji reactions to answer as I read out each question. So first, the clapping hands emoji if you've done a lung ultrasound course. and the heart emoji for anyone that has used ultrasound clinically ever. The thumbs up emoji if you are currently using it as part of your practice regularly. And the celebration emoji if you are wishing to begin using lung ultrasound in your unit. Cool. Excellent. Thanks, guys. So today we'll run through some of these items. So the basics of setting up the ultrasound machine for clinical use, interpretation of the images you may see on lung ultrasound, the use of a scanning tool to score lung aeration, some examples of its clinical use in physiotherapy, and our implementation process at QCH. So imaging is quite a commonly used tool to diagnose lung pathology, monitor its course, and guide clinical management. As physios, we are frequently looking at our patients' most recent chest x-rays and CTs to guide our treatment. They certainly add another layer of depth to our clinical reasoning and provide another piece of the puzzle that is our patient. But what if we had the ability to have this degree of insight at the bedside, radiation-free? That's what lung ultrasound gives us. It's a surface imaging technique and owes its accuracy to the fact that nearly all lung pathologies relevant to the critically ill have a peripheral manifestation. It can differentiate between numerous pathologies, including consolidation, interstitial syndrome, atelectasis, and pleural effusions. We can use it to measure diaphragm thickness and excursion, and it has been suggested as a valuable supplement to respiratory assessment for physiotherapists in critical care. So where we began was that 5 little physiotherapists went out one day and we attended a training course on lung ultrasound by an accredited sonographer, a selection of senior clinicians, researchers, and consultant-level therapists. And when we were there, I learned that lung ultrasound images are not that exciting. They're certainly not exciting as the ultrasound of my baby. I mean, it's a little bit of black, a little bit of white, a little bit of grey, doesn't even look like a lung. But that's because of how ultrasound works. So what happens is that the sound waves bounce off and travel through different structures of different densities, and they return echoes back to the transducer to create an image. The image is based on how long it takes the echo to be received from when it was transmitted, and also how strong that echo is. The machine can then locate which pixel on the screen to light up and how brightly to light it up. And this produces the varying shades of grey that we see on an ultrasound image, and that reflects the variation in densities of the tissue that the sound waves are hitting. Now, your lungs are hopefully full of air, which obviously isn't dense and it doesn't conduct sound waves well. So you get immediate scattering of the sound waves at the pleural air interface, and almost all of the waves are reflected here back to the probe. But it's this reflection, refraction, and transmission of the sound waves altered by the air-fluid ratio throughout the lung, which is what determines the characteristics of the image produced and allows us to comment on the state of aeration of the lung. These laws of physics are why ultrasound is more of a twinkle, twinkle little artifact, how I wonder what you are, rather than actual visualization of the lung tissue. And one of the reasons why ultrasound of the lung doesn't look like a baby. Now, in order to create as clear an image as possible, you do need to understand some of the features on the ultrasound machine, which you can manipulate for clinical use. It does involve a bit of physics, so get your brains ready. But I also will flag that given that the session is only 1 hour, we won't be going into depth around all the physical properties of ultrasound. Now, although the location of various buttons, etc., will change per machine, the features will remain the same. So it's just a matter of finding them on your machine. Also, keep in mind that you may have access to ultrasound machines where you least expect them. So not only may they be in your PICU for medical use, for inserting lines, etc., but you may also find some in your physiotherapy outpatient department for use in musculoskeletal or continence clinics. So first, your probe choice. There are different frequencies and shapes of the ultrasound probes. The high frequency linear probe with the flat edge is the one that we, most frequently use in our unit. The higher frequency gives a better quality image, which makes it easier to identify artifacts. However, the sound waves are more readily absorbed by the surface tissues, which limits the depth of penetration. We've found it gives good visibility to a depth of up to about 6 centimetres, which is suitable for most of our small children, again, keeping in mind the peripheral manifestation of most lung pathology. We find that this probe is generally a good option for up to around the age of 6 to 8 years old. You'll see that the image projected on the screen is rectangular in shape for this probe. In our larger kids or those with more soft tissue to image through, the low-frequency curvilinear probe with the curved surface is most useful. But keep in mind here that the image quality will be inferior. Of course, you can always swap between the two during your scanning, so you can start with the linear probe, and if you get to a point where you need more depth in your image, if you start to scan posteriorly and then you've got more muscle bulk to image through, then you can just simply change probes. You'll also notice a difference in the shape of the image on the screen. So the linear probe images were rectangular. The curvilinear probe has this more sort of cone-shaped projection. Gain is the brightness, intensity, or amplitude. It's essentially a uniform amplification of the ultrasound signal returning to the probe, which makes the signal appear stronger than it actually is. And the stronger the signal, the easier it is to see. So the whole image is whitened by a uniform margin, and this is what we adjust to maximize the contrast between tissues to get the most accurate image. However, the key is in the balance here. So too much brightness, like this middle image, and you lose the detail and you get extra artifact that can make the interpretation a bit more confusing. Some machines also have an auto gain function, which will automatically balance the image for you. Attenuation is a phenomenon whereby ultrasound wave amplitude becomes smaller as it penetrates tissue, as shown in this diagram. Absorption of some of the ultrasound wave by the tissues it travels through also occurs. And these two phenomena are the reason for the darker field at the bottom of the ultrasound image, known as the far field. Time gain compensation is a feature which essentially compensates for this attenuation and absorption. So with this setting, you can choose a part of the image in which to amplify the signal, so that instead of the uniform level of whiteness applied with the single gain adjustment on the previous slide, which may cause that loss of detail in your superficial structures and the extra artifacts, you can choose to brighten just the darker areas. And so that similar interfaces are displayed at a similar level of brightness on the screen, regardless of their depth. And you can also alter the depth of the image within a few centimetres. The depth range is dictated by the frequency range on your chosen transducer. Having a higher frequency gives clearer pictures, but if the waves don't penetrate to a sufficient depth, then you may miss the structure that you actually want to see. Increasing the depth will allow you to see further into the body, but it requires a lower frequency and thus reduced resolution. Essentially, you want to have the entire area of interest in the field and aim for as shallow as possible to enable as high a frequency and best resolution as possible. But isn't this already done for us? What about those presets? So presets are a particular combination of all of the settings that we've just discussed, which most commonly give the best image for a particular part of the body. And they're a good place to start, but they don't eliminate the need to understand the individual settings, as you will frequently need to tweak from here to enhance the image and allow you to accurately and consistently score your lung aeration. Now, all of the images that we've looked at so far have been shot in what's called B mode, which stands for brightness mode, and it's the most common mode that we use. It gives a 2D image of the acoustic impedance of a cross-section of tissue. M mode stands for motion mode, and that's where a single beam is emitted from the probe through the tissues, and it's used to highlight how different structures move relative to each other and to the probe. With lung ultrasound, this can be used, for example, in identifying movement of the pleura and also movement of the diaphragm. Okay, so that's most of the physics talk done for the evening. Of course, we will go into more detail around how we use all of this clinically and what it looks like in the lung, but does anyone have any questions so far on any of the features of the machine? Nothing in the chat?
Nothing in the chat, yeah.
So what we might do now is give you guys a go at troubleshooting some images and working out which of the settings that you'd alter for each to give you the best picture. So get those little emojis ready.
And remember, we are using the reaction buttons down the bottom of the screen there. So which probe would you choose for specifically assessing the pleura? So if you choose the clapping hands emoji, if you think that you would use the low frequency curvilinear probe, or choose the heart emoji if you think that you would use the high frequency linear probe. Seeing a lot of heart emojis. Okay, so you're correct if you chose the high frequency linear probe, which allows clearer images of the superficial structures, just like the pleura. Okay, so how could we make this image clearer? Use the clapping hand emoji if you would increase the gain or the TGC. Use the heart emoji if you would increase the depth. Clapping. Okay. The correct answer here is increasing the gain or the TGC. So this is going to bring a bit more whiteness or brightness to the whole image. If you increase the depth, that would give you poorer resolution and a darker far field. So it would make it a bit harder to see further down. Okay, and finally this one. So how could we make this image clearer? So if you use your clapping hand emoji, this is reducing the gain. Use the heart emoji if you would reduce the depth. Okay. So we would reduce the depth. If you can see on the side there, it's a bit small, but we've got 15 centimeters of depth here. So we've got plenty of room to reduce the depth for increased resolution. So if we reduce the gain on this, again, it would make the image a bit darker and harder to see.
Great. So now we'll move on to what we see when we actually ultrasound the lung. And these are the features that we're going to cover today. So this image here is of A lines, which is what we see in normally aerated lung tissue. So nearly all of the sound waves are immediately reflected back to the probe, and you see this reflection of the pleural line, which is this hyperechoic line here. Hyperechoic is the term used to describe brighter areas on an image. Hypoechoic areas are darker, and anechoic areas are black. This image down the bottom is a different patient with A lines, but gives a nice clear picture of where the ribs are, which is what's casting these black shadows here. And they're called, wait for it, rib shadows. Rib shadows are a good orientation marker to ensure that you're over the thoracic cavity and not the abdomen. In this image here, it's a little more obvious to observe what we call lung slide, which is this shimmering appearance of the pleural line, indicating movement of the pleura with respiration. And this indicates the presence of ventilation. This is what reduced lung slide and lung pulse look like in B mode. Now, lung pulse is a feature which can be present in the absence of lung sliding. And this is where instead of the normal horizontal movement of the pleural line with lung slide, you see a vertical movement of the pleura in sync with the cardiac rhythm, and it implies the absence of ventilation. If we change over to M mode or motion mode, and we continue to look at the pleural line, we should see what's called the seashore sign. So subcutaneous tissue above the pleural line is still and generates horizontal straight lines, and there's a sandy appearance below the pleural line created by movement of the lung. If you see the barcode or stratosphere sign in M mode, this is an indication that lung sliding is reduced or absent. And this occurs in conditions resulting in low tidal volumes like massive atelectasis, pulmonary contusion, or ARDS with low compliance. Lung slide will also be reduced in hyperinflated lungs, and it will be absent, also known as sliding abolition, in any condition in which the pleura are either not directly opposed, like a pneumothorax or an effusion, or if they're stuck together, as in a pleurodesis, or sometimes even in pneumonia or ARDS. Now, continuing along in B mode, as we start to get conditions in the lung which result in partial loss of aeration, more of the ultrasound beams will start to move through the lung tissue rather than being immediately reflected at the pleura. And this will produce some different artifacts. And the features of those artifacts will vary according to the physical properties of what it is that the sound waves are travelling through or bouncing off and how much aeration is present. B lines are caused by thickening of the alveolar interlobular septum from fluid or fibrosis, and it's represented by these blue circles here in this diagram. On imaging, it looks like these long vertical lines which arise from the pleural line and project right down to the bottom of the image. When scanning a particular zone, it's considered positive for B lines if there are 3 or more within a rib space. B lines which are close together are believed to be a sign of alveolar disease, like ARDS, interstitial pneumonia, pulmonary fibrosis. And if they have wider separation, it's more likely to be interstitial lung disease. In conditions where there is very severe edema, these lines become coalesced and almost entirely white between each rib. So you can see the dark rib shadows here and the white appearance of these coalesced B lines that they create between them. More diffuse areas of B lines will be seen in conditions such as pulmonary edema related to fluid overload, cardiac failure, etc., and more focal areas of B lines in cases of interstitial pneumonia, atelectasis, contusion, or lung fibrosis. And finally, we can see what consolidated lung looks like. And here we actually do get to see the lung tissue itself because there's now a complete absence of air caused by collapse or fluid. We don't get the artifacts that the reflection of air causes. There's good transmission of the sound waves, and thus we see the tissue. It's also known as lung hepatization, as the lung appears similar to the liver on ultrasound. Now, this tissue-like sign is seen in translobar consolidation, where the alveoli of an entire lobe are fluid-filled. You can see in this image here with a bit more depth that the lung dimensions are maintained from top to bottom, and you may even see the posterior chest wall and the vertebral column. Where there is partial consolidation, you'll see the shred sign. This is an irregularly shaped boundary between consolidated lung and aerated lung. There is a deep superficial border that's shredded along the consolidated lung, and then aerated lung beneath is identified by sliding and B lines. The shred sign is highly suggestive of pneumonia. So how do we work out whether the cause of absence of air is collapse or consolidation? We look for these things called air bronchograms. These are white dots and lines within the image. A dynamic air bronchogram will appear as a white line which grows with respiration and is specific to pneumonia. Static air bronchograms do not change with the respiration, and they're more indicative of atelectasis. However, they can be seen in up to a third of pneumonia cases. And so, of course, if you see static air bronchograms, you need to refer back to the overall clinical presentation to further differentiate. In significant collapse, you'd expect to see other associated signs like a raised hemidiaphragm, things like that. So we always take the interpretation of these images back to the patient's clinical history. Now, although as physios we aren't using lung ultrasound diagnostically, it's important to know what a pleural effusion and a pneumothorax looks like, so that if you come across these incidentally during your scanning, then you can alert the medical team to do further investigation if they wish to do so. So we won't spend too much time on these two pathologies, but we will cover the basics. So a pleural effusion will look like this. It's a large black anechoic area, usually in the dependent parts of the lung. So in the supine patient, that will be posteriorly. In this image, you can see the diaphragm here, the large black pleural effusion, and the bit of compressed lung flapping away there. You can also see what's called the spine sign. And this is because fluid conducts sound waves well. And that allows deeper structures like the spine to receive higher amplitude echoes. And that makes the image appear more clear. This is a simple effusion. So you'll also be able to view septated effusions, like in this image, as fibrin begins to be laid down in your empyemas, your more complex effusions, etc. So here's the diaphragm, here's your loculated effusion. We've got some B lines coming through here as you start to move into some aerated lung. From a pneumothorax perspective, there's a lovely flow diagram by Volpicelli, which can quickly rule pneumothorax in or out. Now, air will, of course, collect anteriorly in the supine patient. So by placing the probe on the highest point on the anterior chest wall and showing lung slide, then you can rule out a pneumothorax. Also, if you see B lines, this is another indicator that the pleural layers are opposed and that there's no pneumothorax. If you don't see B lines or lung slide, you can then look for the lung point. And this is the point at which the two pleural layers meet again and can usually be found by moving the probe laterally. So you're looking for the point at which the lung slide appears and then disappears. And if you see this, it definitively rules in a pneumothorax. If you can't see the lung point, you can look for lung pulse. Now remember, lung pulse is where the pleural line doesn't slide along horizontally, but instead pulses in time with the cardiac rhythm. You'll only see lung pulse if the pleural layers are still adjacent to one another and if the cardiac pulsation is able to be transmitted to the pleura. So if you see lung pulse, then there's no pneumothorax. So ultrasound is also useful in measuring diaphragm function, and it can identify paralysis as well as dysfunction from other causes, such as prolonged mechanical ventilation, neuromuscular disease, or trauma. We can start with a simple visual assessment by placing the low-frequency curvilinear probe on the chest and watching that diaphragm movement. Paradoxical movement will indicate phrenic nerve palsy. We can then measure the diaphragm excursion by placing the curvilinear probe in a transverse orientation subcostally. We change to M mode, and you should see a nice wave in this hyperechoic line, which is the diaphragm on inspiration and expiration moving towards the probe, away from the probe. Keep in mind with this orientation of your probe, you're scanning through the liver on the right and the spleen on the left. The liver is a nice reliable point to ultrasound through, and so measurements of the right diaphragm are much more reproducible if you're doing multiple scans on a single patient over time. Imaging the left diaphragm is a little bit more difficult as the spleen's a bit of a small window to scan through, and it can be displaced by the ever-changing stomach, which is adjacent to it. And apart from food, what else might be in your stomach? Air. What does air do to ultrasound beams? Lots and lots of reflection. So you may need to come a little bit more laterally when you're trying to get a good view of the left diaphragm. So we can then take some measurements in M mode to get some objective numbers for excursion. So low amplitude can reflect atelectasis, low tidal volumes, raised intra-abdominal pressure, or muscle weakness. And this paper here by Boussage gives some useful tables which summarize your normal values. The subxiphoid view is particularly useful in children. Here you can see both the right and the left hemidiaphragms to allow a bit of a qualitative comparison of their excursion. So here we can see the two sides moving nice and equally with each breath, and then you can just change over to M mode as in the previous slide to do your objective measures. We can also measure the diaphragm thickness with a high-frequency linear probe at the zone of apposition. That's the point where the diaphragm actually meets the ribs. And here you can see the white pleural membrane, peritoneal membrane, and then the diaphragm muscle in between with a fibrous band through the centre. The most accurate measure of diaphragm thickening will come from measuring a patient's maximal inspiration. However, if this isn't possible, you can still get useful information from measurements taken during quiet breathing. Most papers report measuring the distance from the middle of the pleural membrane to the middle of the peritoneal membrane. To help diagnose diaphragm dysfunction, the most common equation used is the diaphragm thickening fraction, which is the percentage increase in thickness, again, ideally on a deep inspiration. In this patient here, there was a 50% increase in thickness with a DTF greater than 20% being considered to be normal by most. This percentage can also be used as a predictor of successful extubation in adults. Again, this paper by Boussage has a nice summary table of average values of hemidiaphragm thickness and DTF. With all of your diaphragm measurements that we've discussed, you should always take 3 measurements and then calculate the average. Okay, how are we still doing? Everyone still with us? Any questions so far?
Have the new in chat.
Cool. All right, so let's move on to how we use it in physiotherapy. So again, it's important to stress we don't use it for diagnostic purposes, but rather to score the level of aeration in the lung. And this scoring then aids our clinical decision-making in the same way that auscultation and palpation does. At QCH, we use this particular tool described by Via and used by Bomad on his paper on ultrasound for lung monitoring of ventilated patients. This paper reviewed how lung ultrasound can be used for setting mechanical ventilation parameters and then monitoring the effects of any therapy aimed at improving aeration. Of course, we know that tweaking settings on a ventilator isn't the only way to improve lung aeration. So this, of course, is a main goal of our physio-respiratory treatments. So what better scoring tool for us to use as well to guide the effects of our interventions? So the tool scores 6 zones on each lung, upper and lower anteriorly, laterally, and posteriorly. Keep an eye on where the diaphragm is to ensure that you're not confusing the liver or spleen with consolidated lung. Each of the zones is then scored 0 to 3, using the worst finding in each area. So 0 is normal aeration, 1 is felines greater than or equal to 3 per rib space, 2 is coalesced felines, and 3 is consolidated lung. You score each zone to give an overall indication of aeration in each of the 12 zones, and then add them up to give a total score of 36, where the higher the number, the more lung pathology is present. On the tool itself, there are also some acronyms for effusion, pneumothorax, sliding abolition, and lung pulse, which you can add in if any of those features are present. At QCH, we began having 2 therapists scanning to reach consensus on scoring each zone, and we found that this was particularly useful in the early stages, and we had really good, reliable scoring between the 2 of us. So looking at some examples, this would be a 0, a 1, a 2, and a 3. A couple of practical points. Just make sure you're using a good amount of ultrasound gel on the probe. So remember that ultrasound waves will reflect strongly when air is present. So without this medium to conduct the sound waves between the probe and the skin, you won't get a decent image. Turn down the lighting in the room to make the machine screen a bit clearer. Make sure you position the patient consistently for any subsequent scans. And keep in mind that raising the arm above the patient's head is an option for increasing the intercostal space to view through.
Okay, so here's what it's going to look like at the bedside, scoring just one side of the chest. So this is a 10-year-old girl with a complex cardiac background, and she had a cardiac arrest and she required ECMO. Okay, so this is a small subpleural consolidation with coalesced B lines underneath. This patient scored a 3 for consolidation. So we can also see in this image some lung pulse. This zone is a 1. So on here, we've got our pleural line, and we can see here we've got at least 3 B lines. And again, we can see some lung pulse. This big dark area here, this is our rib shadow. Now in this segment, we scored this one a 0, as there's only 2 B lines. We do see them there, but remember, we've got to have at least 3 for it to score a 1. You'll also notice in this image, there's some lung pulse and there's no lung slide, and this is a rib shadow. Okay, this image we gave a 1, so we can see that there's at least 4 B lines. This is the pleural line here, no lung slide again, and with lung pulse again. This one, apologies, we accidentally took a photo instead of a video, but you can still see the features. This one, we gave a 0, so we've got a nice clear pleural line here, and you can see down here some more A lines. Again, this is a big rib shadow, which is kind of obscuring a lot of the image, but with little chests, you kind of don't have a choice. This region is also a 0 with the pleural line here and A lines below, and it's got some good lung slide. So this is what it would look like when we input the numbers on the tool, just for the left lung, which gives a total aeration score down here of 5. And to that, you would add the numbers from the right side, and that will give you your overall final score. So now it's your turn. So just please note the chest wall on the diagram is on the right to illustrate which of the 6 zones we're imaging. So you can see this picture here. But the image over here might not necessarily be that same side. So we're going to have a go at scoring some of these images. With this one, you can select more than one answer in the options provided, and we're using the emojis again. So start by choosing the scoring number, which you think best fits, and then any of the other features that you think are present. So have a go scoring those ones. If you think we've got B lines, we're going to use the clapping. If you think it's coalesced B lines, we'll go a heart. And then any of the other features that you see. Okay, so what do we think? We thought that this zone would score a 2. So we've got some coalesced B lines here. This is the white part of the lung. There's also a sliding abolition with no movement at the pleural line up here, and there is some lung pulse. Okay, and what do we think of this one? So have a go. Remember, pick the number that you think it will be first, and then any of the other features that you see. How are we going? Okay. So this zone, we would score this one a 3. This is compressive atelectasis from the pleural effusion, which is this large black area here. So you can see there's also some air bronchograms down in this part. All right. So we'll have another go. choose your number and then pick those features that you see. This is a 6-year-old with DMD. They had influenza. Seeing lots of clapping. Nice work. So this zone scores a 0. So we've got nice aerated lung. We've got a clear pleural line here and all these nice A lines underneath. Okay, next. So we'll choose the clapping hand if we think that those are coalesced B lines. We'll choose a heart if that looks like consolidation, and have a think about the other features that we see. Nice one. Okay, so for this zone, we chose a 3. But for those of you who scored this as a 2 with coalesced B lines, you'd be pretty close. So looking at these ones, you'd be right. But what we have is a small pocket of consolidated lung up here, which gives us a shredded inferior border. And then there's the coalesced B lines underneath it. So given that we have to score the worst feature, this region should be scored as a 3. So this image demonstrates that it can be tricky to score sometimes, and it's really easy to miss those small details, especially if you haven't optimized the image with those various machine settings. Okay, this one, have another go. If we see A lines, we're choosing 0. That's a clap. If we think it's consolidation, we're going to choose a heart and then pick the features. Okay, good one. So this zone is a 3. So here we have the diaphragm, and there's a compressed piece of lung here with some static air bronchograms. And there's also a pleural effusion in this dark space up here. Okay, what are we looking at here? If we think consolidation, we're going to choose claps. If we think that's a liver, we're going to choose a heart. Pleural effusion is a surprised face. It's party for the diaphragm. Okay, so this part here is the liver. And here we've got the diaphragm. If you look really closely, this line here. And what we're looking at there is the zone of apposition. So remember, if you're unsure of whether you're looking at lung or not, if you move your probe around, keep an eye out for the diaphragm and just look for that hyperechoic pleural line, which will tell you that you are over the lung. So we've got another one. Have a go, see what you think. Okay. This zone here would score a 3. So another look at focal consolidation. What we have here is a shred sign, and we've got some coalesced B lines below. Another one. We're getting used to it, I think. All right. So this one is going to score a 0. What we have here is normal lung in this part with some A lines. You can see them shining through here. We've got a good lung slide, and here is the diaphragm. So interestingly, this is the movement of the liver in and out of the frame at the side here. So this is what's known as the curtain sign. All right, last one. What do we think? Surprised faces I'm seeing. Nice work. So this little person was fluid overload, and she scores a 1 in this region for spaced out B lines here. You can see an A line here, but remember, because we're scoring the worst feature in the zone, she gets the score for the B lines. So for those with keen eyes, there's also a bit of a pleural effusion in this one. Yeah. And we've got a nice rib shadow there obscuring everything. All right, nice work.
Great work, everyone. Thanks for having a go. All right, so next we're going to run through some case studies just to give you guys some examples of the varied clinical use of lung ultrasound within physio and some of our patients here at QCH. So although our other methods of assessment like auscultation and chest x-ray give us some idea of what might be happening in the lungs, lung ultrasound has much higher sensitivity and specificity in characterising the pleural and lung pathology. So our first case, it's enabled us to ensure that we're treating current pathology. So this is a little 3-year-old child with spinal muscular atrophy type 1 who came in for her respiratory outpatient appointment. Her chest CT a week prior showed some collapse of her lingual and middle lobe. Now, normally for this little girl, when this sort of thing had happened in the past, we would be looking at parents performing twice daily physio to reverse the collapse, and then there would be obviously subsequent follow-up to ensure it was reinflated. But this was what we saw on her lung ultrasound. She had A lines and they were in all regions. So she had good aeration throughout. She scored 0s in all of her zones. And in this circumstance, the use of lung ultrasound in combination with our traditional assessment techniques demonstrated that the lung had already re-recruited and that actually no treatment was indicated here. So in this instance, the use of lung ultrasound avoided unnecessary treatments and an unnecessary burden on parents that were already very busy caring for their child with a chronic medical condition. And so we sent them all the way. It's also enabled us to provide feedback to our medical colleagues in the readiness to wean ventilation settings and modes or prepare for extubation. So our next patient is a 3-year-old girl with trisomy 21 and narrowing of her spinal canal. She had surgery in a halo to stabilise her spine, but given her potential for a high spinal cord injury, I popped in to see how her diaphragm was going and also to get an idea of her secretion load. Imaging was pretty tricky around her halo jacket, but she scored 0s in all lateral and posterior zones. She was down to extubatable settings on the ventilator. Her diaphragm, however, looked like this. Her right side was contracting and thus demonstrating thickening on inspiration with a DTF of 33% after measuring, remembering that anything above 20% is considered normal. Her left hemidiaphragm was moving passively with respiration, but not actually thickening, so not contracting. And this was even more obvious looking at the subcostal views for her excursion. So we can clearly see movement of the diaphragm on the right side, but nothing on the left. Given that she looked good on minimal settings on the ventilator with a minimal secretion load, the medical team were happy to trial extubation onto low-flow nasal prongs. Over the next 48 hours, she had 2 events of decompensation. One improved with the application of BiPAP and diuresis, the other with reintubation, bronch and physio, with the intensive at that point reporting that what is becoming obvious is the degree of respiratory compromise that this patient may now have due to an evolving deterioration in cord function and diaphragm palsy. So even though it still looked worth trialling the extubation in the first instance, when reintubation was required, there was a greater understanding of the contributing factors for her decline and then how to plan differently next time, such as extubating straight onto BiPAP. We've also used it to help guide our technique choice. So this young man is 15 years old with Duchenne muscular dystrophy. He had progressive chest x-ray changes with persistent right lower lobe collapse and left-sided opacification that wasn't making much improvement despite regular physio input. So we used lung ultrasound pre and post his standard treatment, which was still achieving sputum clearance, but it wasn't really resulting in any change in aeration when we scanned post-treatment. So then we used it pre and post introduction of the intrapulmonary percussive ventilator with settings to target peripheral secretion clearance. The lung ultrasound indicated that the IPV was successful in improving both his secretion clearance and lung aeration. So here we see the consolidated lung with maybe some V lines here, moving through post-treatment into some coalesced V lines as air starts to then move into this part of the lung and causes more of those reflection artifacts rather than being solidly down over here. We've also used it to better target our treatments. So again, rather than just relying on chest X-ray and physical assessment findings. So which segments of the lung are most affected, and thus how we would choose to position our patients for treatment or for resting between treatments to allow VQ matching as well as possible, as well as our secretion drainage positions. So in this baby post-cardiac surgery, her chest X-ray was reported as ill-defined opacities in her left lower lobe. On lung ultrasound, she scored 1s and 2s throughout her entire left side, but her right side also showed some atelectasis in her right upper lobe and also some consolidation and a small effusion in her right lower lobe. Also, if indications for chest physiotherapy are unclear, it provides some aid to our differential diagnosis. So this is a young lady who was post-pancreatic surgery with temperatures, increasing oxygen requirement and shortness of breath at rest. Chest physiotherapy was requested, but on lung ultrasound, this is what we found. So she actually had some decent sized pleural effusions bilaterally, with the left being a bit larger and also containing some fibrinous strands, if you can see those through here and here. She then had a chest X-ray, but again, you can see how this is much less specific than that ultrasound image, particularly on her right side. It really doesn't look that bad compared to what it looks like on her ultrasound. Lung ultrasound is also useful for us to be able to track an area of pathology across the patient's admission. And we've even started to use it as the diaphragm measurements to monitor the effects of inspiratory muscle training programs. Now, as much as we've spent this session discussing how great ultrasound can be in informing your clinical decision-making, it's important to ensure you've got strong governance and a rigorous planning and implementation process prior to its clinical use, so that the sonographers, intensivists, and nursing staff aren't like this guy. So first, it's essential to engage key stakeholders across multiple disciplines. There's nothing quite like being part of a keen team. So having some great people to work with across the medical and medical imaging teams was huge for us. We had regular conversations with them to provide education around what our physiotherapy use of lung ultrasound was for, and they in turn were interested in what we were doing. They could understand its value within our discipline, and they contributed constructive feedback around any concerns that they had. This dialogue enabled us to ensure that issues from all angles were addressed prior to the implementation. And these same stakeholders then reviewed our proposed guidelines, which covered things like patient selection, storage of images and consent, and the time and the framing around our use of ultrasound to guide clinical decision-making and not for diagnosing pathology. We then kept the doors of communication open, having ongoing discussions with this group long after we started using lung ultrasound. So they were kept up to date of our progress and provided an avenue for raising any concerns which may have come about after the implementation. It's also helpful to draw on the expertise of those around you who may often be outside of your discipline, because there's always someone who has thought of a way to do something a little bit differently. So for us, it was the question of, once we'd had the basics down from our course and had a chance for a little bit of practice, where do we then go for troubleshooting those tricky images? What are the little nuances around probe positioning, etc., the little tips and tricks that only experience and learning from those with that experience brings? So we linked in with a consultant level sonographer in our medical imaging department who supports our continuing education through buddy treatments at the bedside and viewing little video clips that we've taken that we sent through to him. Working in a department that supports innovation and has got your back was another big enabler. I've worked in many physio departments around the world and in Australia, and when staff feel empowered to wish I may, wish I might, have the wish I wish tonight, that's when the magic happens. So a physio director and physiotherapy consultant who have your back when it comes to training, support, and subsequent development of lung ultrasound for clinical use is a great help. Now, if you're looking at starting to use lung ultrasound in your unit, some things to be aware of when you first begin. It will take some time for you to learn, so be prepared for your scoring process to take around 20 to 30 minutes when you first begin. So more often than not, the chests that we're scanning are much more complex than the nice, clear textbook pictures that you learn from, and sometimes the interpretation of what you're seeing isn't obvious. However, it does get to the point where it takes around 5 minutes, again, depending on how complex the lung changes are, if you're saving images, if you have a crying baby or a possessed 2-year-old, those sorts of things. Use the best machine that you have access to. So our PICU machines are much more advanced than our outpatient physiotherapy department ones. So we use the PICU ones as much as possible for clearer images because they're a whole lot easier to interpret, especially when you're learning. Practice as much as you can. So try to do at least one scan every day. So fitting scans into a day of clinical and non-clinical commitments can sometimes mean that we don't get to scan every patient we would otherwise choose to, but aiming for at least one per day gives the opportunity for regular practice. Find a practical way to set up your scoring tool of choice. So we created a QR code, which is laminated, attached to our staff ID card, and that QR code links to a digital version of the 6 zones scoring tool that we've described in this presentation. Again, it's something that we created, but it's also a useful point to refer back to the data at any point in time. Tee up some buddy scans with another learner, or even better, if you can find someone who has expertise in lung ultrasound within your unit, particularly with the more difficult scans like patients with chest wall deformities, scoliosis, things like that. And maintain a quality focus. So take the time to establish the use of lung ultrasound appropriately, improve your own learning and abilities, and iron out any creases in the process prior to training others. Initiating lung ultrasound had many physios keen to learn the technique, and it was key for us to continue its use within our group of trained clinicians until we ourselves became proficient first. So what's next for us? We've completed a research project looking at intra and inter-rater reliability of diaphragm ultrasound measurements in critically ill children, and the abstract has been accepted for WIFPICS this year. As there are not many of the initial 5 trained physios still in our department, we've hosted another training course for 4 others to be trained also. And these staff members come from our critical care team, our respiratory inpatient wards, and also our hospital in the home team. And that's in order to expand our cohort of patients that we're able to use lung ultrasound on. As Ali mentioned at the start of the presentation, I've just gone through the process of obtaining my certificate in Allied Health Performed Ultrasound from the Australian Society for Ultrasound in Medicine. We're also in the final stages of creating an online education package to support the training of physios who work within a department such as ours, where there's already a skilled clinician in lung ultrasound. So if anyone is interested in that resource once finalised, please just email us your details. We'd love to hear from you. And of course, when you're onto something so good, you just want to share it with all your colleagues. So we're happy to be an advisory source for other critical care physios wherever they may be, so that they too can initiate their training process and use of lung ultrasound within their unit. Any questions? Now, I've put my Twitter, oh no, it's X now, isn't it? Not Twitter. Handle up, like I'm all over this X business, but I'm not. I'm an X rookie, but feel free to educate me on a thing or two in this arena. Has anyone got any questions or comments? Feel free to type in the chat box if you're we finish.
Okay.
So Sarah Wright's popped in a comment. Can I ask who has used lung ultrasound who is currently online? Do you know some certifications for physios in Europe? Not off the top of my head, I'm sorry. I could definitely find out for you though. Maybe if you're happy to either send me an email. Sorry, I missed your, sorry, there's lots of comments here. Alessia. Alessia, if you just want to flick through an email. So if you just take note of Cam and I's email there and just send through an email, and I can definitely find that information out for you.
Jenny's asked, do you ever roll your patients to access the posterior scan regions better?
Ideally not. I tend to find I can get the access to the posterior by just bring the hand across the chest. And that's just because as soon as you move patients, like if you've got an effusion or something like that, it's all just going to change where everything's going. So it's the same as, you know, if you're auscultating a patient and you move them, then you can alter your baseline observation. So it's the same sort of idea with your ultrasound. So if you can image them as they lie, then I tend to go with that. You can ultrasound in different positions though. So you can certainly ultrasound in your more mobile patients. You can ultrasound them in seated positions, things like that. But yeah, I tend to just be able to get enough visibility if you just bring their arm across their chest.
There can sometimes be a little bit of wedging that ultrasound probe kind of into the mattress to be able to get to those posterior segments, but we can get there.
There's a question there from Sonia. Do you systematically use lung ultrasound pre-extubation? Diagnostic ultrasound?
Not routinely, no. I think it's got a lot of evidence behind it in the adult world as far as pre-extubation, looking at, you know, predicting what the extubation success is going to be using various parameters, but it's not hugely looked at in peds. And certainly at the moment, we're focused more on that clinical reasoning around our use of it for physio treatments and things like that. But I think within that, as we start to use it more within our unit, then I think we'll be able to use it for those purposes to give our medical team a little bit more information for those kids that we're already treating, potentially pre-extubation. We can get a bit more of an idea of what they might look like post-extubation from what their ultrasound is doing.
Katie has asked about our online package. Is this currently available or a project in progress? Will it be shared publicly?
Yeah, so if you are interested in the online package, so it's being finalised at the moment, so it is a work in progress. But the plan is for that to be accessible for people. So if you would like access to that, if you could just flick us an email just so that we can, you know, send around an email once it's finalised and let you know how you can access that.
It sounds like a number of people at Perth Children's Hospital have undertaken training in lung ultrasound. That's really good.
The politics around rolling it out in physio is tricky. Yeah.
Cool.
And yes, the webinar, the recording of this will be accessible. So Evelyn from WIFPIX will send around the recording after the session.
Well, thank you so much, Cam and Georgie, for that excellent presentation. I feel like it's enlightened many people around the world and inspired. And I think, you know, your commitment and dedication to becoming certified and continuing your training, ultimately for providing best practice and excellence in patient care is, you know, really outstanding. So thank you both so much. There is another question there. How can we differentiate between an infection and atelectasis?
So yeah, so if you're looking at more of your consolidation versus atelectasis, so if you're looking at consolidation, you'll have, so if it's like an infective pneumonia, so that shred sign is really indicative of pneumonia. So if you see that, then you've got more of an infective process, and you'll see more of the dynamic air bronchograms in the infective processes as well. So as the patient breathes in, you'll see that area of consolidation kind of light up with a few white air bronchograms. Whereas in atelectasis, you'll see that a similar looking consolidated lung, but it won't have the shred sign and it won't have those dynamic air bronchograms. You might see a few static ones, so a few little static white lines and things that don't change at all with respiration. So that's how to differentiate.
Thanks, Georgie. Well, if no one else has any more questions, we're just past the hour, so we might finish up. Thank you all so much for participating, and I love the interactivity. I definitely didn't get all the right answers, so I've got a lot of learning to do. Can I all really encourage you to support and promote Allied Health and WIFPICS and WIFPICS Congress in Cancun that is coming up in June. I really hope to see as many as people, as many as our colleagues as we can at the Congress. So as I said in the chat, please share your Twitter name as well. It's a really nice way of being part of the network and sharing resources and education. So if there's no more questions, I think we will sign off.